There are many different products available that are considered natural. That includes eye drops available for the ocular surface conditions. In this episode of OCuTALK, optometrist Emilie Seitz discusses biologic treatment options for ocular surface conditions, how they differ from traditional pharmaceutical options, the different types of products available, and how they work for the patients. Hello and welcome to OcuTalk. Today we're having a conversation with optometrist Emilie Seitz. Doctor, thank you for joining us today.
Thanks for having me.
To get us started, would you mind telling us a little bit about your background and your specialty?
Sure. So I am originally from Cleveland, Ohio. I went to Ohio State for my undergraduate education and did optometry school at the Pennsylvania College of Optometry. After that, I pursued a residency in ocular disease at the VA system in North Carolina and have always been very medically focused. It was there where I was introduced to dry eye treatment and management. And so, following residency, I worked in various dry eye clinics. I brought dry eye into a group practice and created a clinic for about 2.5 years, ran that. And then most recently moved to Ohio in Cincinnati to work at a tertiary dry eye only clinic. So have been very invested over my career with the anterior segment. So I'm super excited to talk about this topic today.
Well, we're very excited too. So, for our audience, today we were hoping you could discuss ocular biologics and how that relates to different ocular surface diseases like dry eye. So, could you tell us what exactly are ocular biologics?
Yeah, I would think about them as kind of newer forms of medicine, but they're really not. We've actually seen them used in many other places outside of eye care. But when we come to defining what a biologic is, I think about it as from the body to heal the body. So these are products or drugs that actually come from living organisms or their components. Other places in medicine that we see them are things like insulin, Humira, which is a biosimilar drug that we use for autoimmune disease. Even COVID vaccines, like mRNA-derived vaccines, are all examples of biologics. For the purpose of today's discussion, we'll talk more about those that have impacts on growth factors because they have impacts and implications for the anterior segment and also the posterior segment of the eye.
So, to get us started, then, how exactly are biologics different from traditional pharmaceutical products when it comes to ocular surface?
There are a few differences. First, in terms of their source, like we said, biologics are going to come from living organisms, whereas traditional drugs are going to be chemically synthesized. The other differences come in terms of their composition. When we think about traditional drugs, they're going to be smaller and they're also going to be more stable. When it comes to biologics, these are going to be larger molecules, more complex, things like proteins and antibodies. And because they are more like a living organism, they're going to be sensitive to things like acidity, pH, also light, and then temperature as well, can all impact how stable these molecules are.
So, what kind of typical biologic agents are used when treating the ocular surface?
Common biologic agents when it comes to ocular surface disease management can include things like amniotic membranes, and we'll talk about things that are what called dry membranes versus wet membranes, and also blood derivatives. Again, coming from the body to heal the body, things like Autologus Serum eye drops or platelet-rich plasma eye drops are all effective biologic agents in healing the ocular surface.
So, how are these biologic agents applied to the ocular surface?
At this point in time, most of our biologic agents are going to be topically administered or topically applied. Things like the membrane sometimes will sit on the front surface, and then we're looking almost for like a diffusion of ingredients with that apposition against that front surface. But there may be some changes in the future. There may actually be some injectable options that will actually improve the anterior segment. So more to come on that. But for now, most are being used with a topical application.
So, what would you say are the key advantages to using biologics over some of the more traditional therapeutic options available?
There can be multiple advantages. I would say one advantage is when we look at adverse effects. With typical and traditional pharmaceuticals, sometimes they do yield adverse events. Patients can be sensitive to some of the molecules that are inside the drug. They're more generic and kind of widespread. But a key advantage with biologics is they can work a little bit more alongside your body, be a more natural process, and also can be a little bit more specific in their pathway, meaning that less side effects occur. The other key advantage I would say of biologics is their impact. Biologics are often targeting a specific cell or pathway, and so they're more effective in their targeted and intended use. Whereas, again, topical pharmaceuticals sometimes have a more broad effect and more general impact overall.
So then what would you say are the common ocular surface conditions in which biologics would be recommended?
So traditionally, we're using them in a lot of scenarios where we have impaired tissue. And impaired corneal tissue really is what we're looking at. When it comes to dry eye disease, sometimes because of chronic inflammation, we can have a sign that we call punctate keratitis, which looks like these little cells indicating front surface damage. And biologics are really great at healing those properties. Other ocular surface conditions can be things like ulcers, either, yes, from prolonged dry eye disease or a neurotrophic component. Maybe the corneal nerves just aren't functioning to their full capacity, and so the cornea itself just can't heal itself. Herpetic eye disease as well can create ulcers where the tissue becomes damaged and has an impaired ability to heal, but also mechanical issues. I've had many patients that have had scratches or abrasions. A baby nail comes over the front surface and extends not only from the cornea but into the conjunctiva as well. And we've seen biologics heal all of these at the front surface. I would say, aside from corneal disease and looking at the tissue damage, we also think biologics may help in things that we can't necessarily perceive by the naked eye. More specifically, this condition I'm talking about is what we call corneal neuropathic pain. Based on patient's symptom and history, the front surface of the eye may look immaculate, it may look impeccable. But for whatever reason, patients end up having a lot of pain that is constantly signaling that it's coming from the eye. We've kind of come to understand that it's the corneal nerves that are getting aggravated, and perhaps inflammation is a key to this. And so we've seen lots of our biologic therapies improve some of the symptoms and the pain that's involved in corneal neuropathic pain.
So you mentioned a little bit earlier something about wet membrane versus dry membrane. So could you tell us a little bit about what they are, their similarities, their differences, what the preparation and storage of them look like?
Yes, it's a little bit of a long process, but there's a lot of similarities between them and how they're prepared, but then how they're stored, and a little bit difference between the preparation occurs later. And this also kind of relates into their functionality. So when we think about the similarities, in terms of preparation, initially it's going to look very similar. With amniotic membranes, it is coming from donated placenta tissue. So they're collected from mothers after consenting to donate their placenta after full term cesarean births. Now, after that process, they're going to screen the tissue extensively. They're looking for any kind of infectious agents, contamination, very similar to blood donation. After that is screened, what they'll do is they'll separate the placenta and take the amnion layer, which is the inner layer. The reason that we're using amnion is because it has a lot of healing properties, anti-inflammatory agents and growth factors, the things that really we're using as a biologic to help with healing. After that process of separation, they're going to go ahead and wash the tissue and test it again for any residual infections, bacteria that might be present. At the very end, they'll sterilize it again using some gamma effect there. Now, when it comes to the differences, we talked just about how it's similar in terms of getting the tissue itself, but when it comes to then processing on and storing, this is where dry versus wet comes into play. So dry membranes are what we refer to as dehydrated membranes. They're going to be air or freeze dried at the end of the process, and it's going to be under sterile conditions. But the benefit of it is it can be stored at room temperature for longer periods of time. The downside in this preparation process is it means that we may lose some of the cellular components over the process, but a lot of the structural proteins remain that help with those signaling pathways for healing. When it comes to preparation then of wet membranes, or we also call these cryopreserved membranes, they're going to use a cryoprotectant solution. I tell patients this is like a very, very strong preservative, but the goal is really to keep as much of that live cell intact. It's also going to be stored at very cold temperatures, about minus 80 degrees Celsius. And that's to protect all the live cells and bioactive molecules that are in that tissue. When it gets to providers, we do need to store it in a freezer to keep that as active as possible. And then prior to insertion, we're actually going to end up thawing it out and rinsing a lot of that preservative or cryoprotectant solution off so it only heals and doesn't cause any damage to the corneal tissue that we're intending to heal.
So, how do you determine which one to use, wet versus dry?
Yes, so everyone's clinical experience is going to be a little bit different. In my clinical experience, sometimes I've made the determination of dry versus wet based on two things: severity, and then also the size of the defect that we're looking at. For smaller areas and less severe defects, I've seen dry membranes perform really well. They are going to be, yes, dehydrated and typically a little bit smaller, but they'll adhere to the front surface of the eye really well. Um, for areas that are larger, just because sometimes the diameter of that dry membrane isn't quite as large, I've seen cryopreserved membranes act really well. So when I was talking earlier about sometimes I've had patients with big scratches that not only go to the cornea, but extend onto the conjunctiva, the wet membranes by far are just going to cover that surface area. When it comes to severity, then sometimes larger, deeper defects or defects that have been more resistant, more chronic, they just perform better with those more active molecules. And so that's where I may end up choosing to use a wet or cryopreserved membrane in those cases.
Okay, so now can you tell us about platelet-rich plasma eye drops? What are those?
Yeah, so we have two different options for biologics when it comes, and actually more than that, but focusing on PRP or platelet-rich plasma and autologous serum eye drops, those are kind of our two most common, I would say, of our biologic blood derivatives. When we talk about autologous serum, they may be more readily available. There are some companies that do some mass production, I would say, just a little bit more wide scale of how they can create autologous serum. But in the autologous serum eye drops, we're actually, yes, doing a blood draw in both of these preparations, but we're taking that liquefied component only, fractioning off the top half. With autologous serum specifically, the important part of this is it's always diluted, and we dilute it with basic saline solution. So when we talk about autologous serum, we always talk about it in terms of concentration. We'll say it's 20%, 30%, 40%, 50%. And those percentages are actually referring to the amount of biologic drop relative to the amount of solution. So 40% autologous serum would mean that it's 40% of those healthy healing properties of the blood element, where 60% is then the saline solution. There's benefits in that, I would say. It means it can last longer. For platelet-rich plasma, we are really using this preparation. Again, same exact idea with a blood draw, but we are actually looking to have the platelets involved. Platelets do offer some superiority when it comes to healing. So when it comes to preparing platelets, we actually have to involve something like an anticoagulant and typically actually use a larger needle so we don't damage the platelets. They are larger than traditional growth factors. So if we want to include them, we need to draw it out with a larger bevel of a needle.
So then how do you determine which one of these to use, the PRP versus the autologous serum eye drops?
Yeah, luckily we have studies to help guide us in this direction. So when I look into performance, sometimes I'll choose PRP over autologous serum when it comes to state of disease. Patients with more severe autoimmune disease or more severe punctate keratitis or ulcers may perform better when it comes to PRP. Even when we've compared actually PRP and autologous serum, when autologous serum was, let's say, at 100% concentration, which, like I was saying earlier, usually it's 20 to 50%. So not as often that it's actually going to be in 100% concentration. But even head to head with PRP performs actually better when it comes to the objectives that we're looking at when we're managing dry eye disease metrics. The other place I would say where PRP may offer an advantage is in how many times you need to use that. With autologous serum, because it's lower in its concentration, I'll actually have patients use them sometimes 6 to 8 times a day. And that's pretty standardized. I don't like to drop much lower below that. But with PRP, because it's more concentrated, we can dose it 4 times a day and still get an extremely effective therapeutic effect and benefit. So when we talk too about, okay, what is actually realistic for patients to be able to do with both of these blood products, you need to keep it cold. And so this idea of keeping it chilled, some patients might not be working from home and be able to go back to the fridge and use it every 2 hours. In the case of autologous serum, that's 8 times a day. PRP may actually be an advantage at just keeping it at 4 times a day. But a lot of the conversation usually comes down to severity. But I will say convenience and how patients are actually using those therapies, that plays a role as well. And I think a lot of us physicians need to consider what is actually realistic for patients to do in the span of their day.
That makes perfect sense. So, what does the process look like for the patient when it comes to being prescribed a biologic eye drop?
Yeah, so for patients, what we would end up doing is one, we'd evaluate them and see, what is the state of their condition? Are they improving on traditional therapies or not even just improving but I would say open to maybe a biologic. I'm finding that a lot of patients these days in an age where we have more customized medicine are actually more open to more natural options. And so sometimes I'll say, I can put you on a traditional pharmaceutical, but we have a more natural route that we can go if that's something that appeals to you. And I've had many patients opt in for biologics over traditional pharmaceutical therapies for that reason. Wanting to be on something that's long term but more natural to their body might be a reason why they want to elect it. Aside from the evaluation and conversation and evaluation of that, when it comes to actually prescribing it, traditionally we'll find different sources, or sometimes for PRP, we actually have to make it in-house itself. It's not as widely administered, but it would consist of doing the blood draw, screening for other things that can sometimes impact the quality of blood, like anemia, or if you're on anticoagulants, this may not be a good option for you because we want platelets to be high in their concentration. But that's kind of how we look at it from the patient perspective, is evaluating them, kind of talking about the treatment options, looking at their signs and symptoms to determine, is a biologic good to introduce at this point in time, or do we even need to wait for a biologic if someone's open to doing it? There's a lot of conversations that are had between patients and physicians to know whether a biologic is the right next step.
So, in terms of use, when we're talking about biologics for ocular surface conditions, are these long-term ongoing treatments or are these short-term treatments to get to an ultimate outcome?
So, when it comes to ocular surface disease, we know that that's a chronic condition. When it comes to amniotic membranes, I would say the benefit is we have seen that even using an amniotic membrane, while we may leave it in for 3 to 5 days or even get healing properties in just a single 24-hour period of time, we've seen that they actually can deliver healing properties even longer. So, when I think about their use and when I think about how to implement them in clinic, they can be kind of placeholders where it's not chronic over a period of time where you have to do this every single year, but more so as a boost to get us farther ahead in our treatment. But because this condition is chronic and progressive, it's always about staying 2 steps ahead of it. And so a lot of times when we think then about either pharmaceutical intervention or, let's say, like biologics from a blood derivative perspective, those are things that we'll always want to stay on top of. I have seen, though, in clinical practice where maybe we'll start dosing something higher, like PRP at 4 times a day, and then as they become more stable, we drop that down to twice a day. But as long as there's inflammation present and there's a chronic inflammatory condition that's occurring, we always need some level of intervention. The question is, how do we kind of make it more manageable for patients?
Well, thank you very much, doctor. That's all very interesting. Is there anything else you want to tell us today?
Yes, I think for the audience, just be open to the numerous advancements in therapies. I know sometimes when we're managing ocular surface disease, and I've managed some of the most severe of it, it can feel very overwhelming and very daunting, but there are many new therapies on the horizon.
Well, thank you very much for joining us today and having this wonderful conversation.
Thank you.